I was just about to say that I would like to thank the organizers for giving me a grand total of 10 minutes to present a topic that nobody else ever talks about. So I'm going to sort of talk about prevent or stabilize progression. And I think we all understand that life expectancies are increasing. And with that comes our duty to make sure that within a person's life, whether they come to us as congenital glaucomas, juvenile glaucomas, POAG, whatever they come to us with, that we can actually prevent or stabilize the glaucoma at that place. And the only way we can do it if we actually pick the progression up early. The earlier we pick it up, the more likely we are to actually end up intervening and therefore preventing any visual disability. So the general management, I'm sure everybody is aware of, but I just want to reiterate that in our country, there are 3 reasons for suspecting glaucoma: a shallow anterior chamber, optic nerve head changes, and raised IOP. And please do not believe that an IOP of 21 millimeters of mercury is normal. Assess, treat all the secondary or primary angle closures with an iridotomy, assess the glaucoma severity, and then come to a target IOP. I would suggest these that are present at the bottom, but I think everybody can determine things for themselves, but these have worked very well for us over the years. Now, why are we talking about progression? It's because it's common. And the higher the intraocular pressure, you can see the intraocular pressure here was 18, and you can see in almost 80% progression rate. We can also see that, there's many things that have happened, and we can actually find out that there is a age-related loss, which is never going to lead to a visual disability. Slow progressors are not going to lead to visual disability. And even with treatment, all we are doing is we are extending the lifetime of vision in those patients. However, the ones that we actually want to diagnose are these fast progressors, where if we pick the progression early, we can actually prevent morbidity. If we do it late, they will at some point get to visual morbidity. What are the reasons for this? A strong family history of blindness due to glaucoma, extremes of age. But when we look at the ocular problems, I think the ones which are sort of most talked about are the severe glaucoma at baseline. And you can take it as a very large or high vertical cup disc ratio. Intervisit IOP fluctuations, which I think we should be more aware of, that today the patient comes, the pressure is 14, the next time he comes, it's 17, the next time he comes, it's 12, and we are sort of saying, okay, he's all right most of the time. But actually, these are the fluctuations that actually cause damage. Then, of course, the kind of glaucoma there is, whether it's an angle closure as compared to an open angle. We know angle closures are more likely to lead to progression. Juvenile open angle glaucomas and pseudoexfoliation. There are many tests that there are for progression, but each of them should actually be able to distinguish variability from actual progression and pick up the earliest change, and ideally not after we've done 5 or 6 tests, but from test to test. Where are we going to look for these changes? I think we're all aware that this is either on the inferior temporal or superior temporal part of the optic nerve head. We're looking for a deepening of existing loss, expansion, or any new defects. And you can use anything. You can use perimetry, OCT, just your examination. But in the early stages, probably a ganglion cell analysis is good. In the moderate stage, anything will do. And in the advanced stage, it's a 10-2, and again, a ganglion cell analysis. Just looking at the optic nerve over time and taking photographs, which also show us the same thing: deepening, expansion, new areas of loss. And you can actually draw a diagram on your clinical record and record exactly the same thing. And this will be corroborated. You can see this very thin RNFL loss. You can see the wider loss 8 years later, and the same thing being shown over time with your perimetry, both as well as trend and event analysis. Perimetry can be used, and it's suggested that you concentrate on already defective locations every time you look, and look for the rate of progression. So in the rate of progression, again, there's some amount of aging that takes place, and for a VFI, it's 1% per year. The progression is anything 2% or more, And for fast progressors, it's more than 5%. These are not sacrosanct. I think people are still evaluating to see what we should do. And I think the newer HFA actually flags that significant change with every test. So this is something that we could look forward to, while the octopus actually gives us cluster trend analysis over time. Imaging has many fallacies. Please do not say that it's objective and therefore, we can take it as the gospel truth. There are problems with centration, the quality of the scan, the presence of artifacts, but still it is more objective than perimetry. And here it is said that aging causes about a 0.5 micron per year loss in RNFL, and therefore more than 10 microns per year loss should definitely be considered to be out of normal range and glaucoma. Again, we're looking for the same things, widening, new defects. Basically, it's the same thing that we look at over time. We have to be aware that there's a floor effect when we get to about moderate to severe glaucomas, and the RNFL may not be used from then onwards. So you have seen that there is a trend analysis and an event analysis on perimetry, exactly the same on OCT, a trend analysis, and showing you a localized loss by the change on RNFL profiles. All OCT machines give us this, the ganglion cell analysis. Again, we are looking at the arcuate loss, and we're looking at widening of this loss or a thinning that is 1 to 1.5 microns per year. How do we manage progression? I think the management will differ on the severity, on what you're following the patient up with, what are the risk factors the patient has, and we're then saying that there's going to be a periodic evaluation for change once you've made a diagnosis of glaucoma. So you're going to be watching out for intervisit fluctuations. You're going to be having some objective record. I think everybody can do a fundus photograph these days. You can make a diagram. Perimetry and imaging, you need at least 5 fields to do any sort of analysis, and imaging, you need at least 4 images. So you are then going to see, is the patient stable and the patient quality of life is maintained, then you're not going to worry too much. If the patient is stable but uncomfortable, you need to do some alteration in the medications. However, if there's progression, this is what we actually have to identify fast progressors, as I've said, and ask the patient the certain questions. Is the target IOP achieved or not? Is the patient compliant or not? Has a gonioscopy been done and recorded? And is there any inadvertent use of steroids? We also have to keep in mind that there are other causes of visual loss which show up as progression, either on the OCT or on the field. So if we are looking at the important ones, you actually have to look for compliance first. You then want to know what is the rate of progression, what stage of the glaucoma, and is the scotoma central or further towards the periphery. We are all aware that the higher the IOP, the more chances of progression. But if the patient himself or herself says that they're not very compliant, I think most often it's because our prescriptions are so difficult. I will talk about prescriptions a little later. So you can simplify the prescription. You can ask them to use phone alarms. You can make sure they actually can afford the medications. On the other hand, if the patient says, I am absolutely compliant, I have nothing else in life to do, I put the drops on at the right time, we have to check the efficacy of the drugs, because we know that 10% of patients are non-responders to all our glaucoma medications. And you also have to check that he hasn't used any steroids, which he has subsequently stopped. And therefore, at this point, the IOP is high and you're beginning to see progression. The last point, of course, is to make sure they know how to put the drops in, that you make a little pocket of the inferior lid and make sure the drop goes in. Close your eyes for a minute and wipe out any excess fluid. So these are target IOP ranges, which I think a lot of you may have seen. For the early defects, it was 15 to 17, 12 to 15, and 10 to 12 for the most severe. So when we are finding that despite reaching these target IOPs, there is progression, the first thing, of course, to do is to move to the higher step. So if you were doing 15 to 17, you move it to 12 to 15. And you reassess and say that if there's a very fast rate of progression, I probably don't need to go to 12 to 15. I need to get to 10 and 12. You find a lot of fluctuations, then you're probably looking at things that keep the IOP controlled for 24 hours, like prostaglandins or surgery. If the fellow eye has already gone blind from glaucoma, you want a very close review after you have reassessed and changed the target IOP. But remember, you must reset both your perimetry and imaging. And this can be done by the last two tests that actually showed you there was progression. So what do we do with the medications? I think you have to remember, and I was telling you these complicated prescriptions. This is the kind of prescription that normally comes to us. Patient has been on medications for the last 3-4 years, and we're not even sure how is he putting, once a day, twice a day, 3 times a day, 4 times a day. So the same kind of, exactly the same drugs can be given in a much more sort of organized manner, twice a day, 15-minute intervals, and 1 at night. So you have to make sure that you are making it simple for the patient. You have to keep telling yourself that both eyes behave similarly, even if asymmetrical. So you might find that one eye has greater damage and we put all our attention to lowering the IOP there. And we forget to look after the better eye. Actually, we should be constantly treating both eyes equally. Check to see whether the beta blockers, which is one of our most effective medications, has not been used for 4 years, 5 years, 10 years, because you might find this tolerance. And if you give a gap for about 6 weeks and then restart, it definitely starts working again. You have to use medications that are working on different outflows. There's no point in having 3 medications working only on the inflow. So if you have timolol, you have dorzolamide, and you have brimonidine, the efficacy of the second and third are going to be less. On the other hand, if you use a timolol that's working on the inflow, PG on the uveoscleral outflow, and ROCK inhibitors on the trabecular outflow, you're probably going to get a much better additive action. So decrease the number of bottles the patient has to actually use by using combinations, and decrease the number of applications. Make it BD as far as possible. The caregiver, the patient, everybody will be much more compliant. But we have to think of surgery, because surgery actually has many advantages. So the indications for surgery in case of a progressive glaucoma would be if there's fast perimetric loss, if there's a central visual field loss which has actually occurred or is threatening, and if there's a moderate to severe disease. What we have seen, now we have data over 10, 20 years, that it's a safe surgery if you use low-dose mitomycin and you use releasable sutures in patients with advanced or severe glaucomas. It reduces the IOP anything from 30 to 60%. It reduces the fluctuation, intervisit fluctuation, diurnal fluctuation. It may, over time, and what we've seen is 4 or 5 years after the trabeculectomy, may need to add additional glaucoma medications. That's not a problem. And maybe about 5% of them may require a repeat surgery in 10 years. However, with medications, 90% of them show qualified success to target IOP over 20 years. And keep in mind that the IOP fluctuations are reduced, plus you no longer have to depend on the patient for compliance, for the ability to go and buy the medications, for the medications to be available. Selective laser trabeculoplasty is something that a lot of people are talking about, and the LIGHT study has recently shown us that if you do a 360-degree selective laser trabeculoplasty, the mean effect, I mean, most of them had less, some of them had more, was 8 millimeters of mercury. So if you're starting at pressures of 26, 28, please remember that you're only going to get to 20. What they have shown as success is a 20% IOP reduction, and said this worked in a large number of ocular hypertensives and mild open-angle glaucomas. Please do not use it for moderate or severe glaucomas, because it will not reduce the IOP adequately. It can be used with medications. The selective laser trabeculoplasty is thought not to work as well in patients who've been on prostaglandins. So just to take a few cases before I end, you have patients with ocular hypertension with an open angle, or a PAC with ocular hypertension. And both the patient and the doctor are not convinced that, the medication is required. So we had this lady whose IOPs were 22, 24, and she was okay. I mean, we didn't give her any medications. Her CCT was about 600. So we thought, okay, let her be. So for 14 years, she came back regularly. She was stable. And then suddenly we saw that there was an increase in IOP to 26, and the visual field fell. So when we went back, we realized that she just in the last year changed the cream that she was using. And when we looked at the cream, there was steroid in it. So in normal fields, remember that, there's not a gradual sort of loss. You can get a sudden loss in vision. And imaging in these cases Here it's an HRT, but with an OCT, you'll be able to pick it up earlier. And here with a GCC, you'll be able to pick up the changes early as well. And these are highlighted in red to show you which are the areas that are changing. What about a POAG suspect? Now you can see the disc is showing us a certain amount of cupping. There's thinning inferior temporally. So this gentleman was told, you have a suspicion of glaucoma. You don't have any visual field loss yet, but you have a family history, come back regularly for a follow-up. And he did. So we had a baseline IOP of 20 to 24. We gave him timolol alone, and for 2 years, he was fine. At the end of 2 years, his IOP started again reaching 20. So we thought, okay, let's add a prostaglandin. Sorry, we switched to a prostaglandin. And after switching to a prostaglandin, what we noticed was that there was a gradual decrease over here, and the rate of progression was now minus 1.5, telling us that we're getting to a point where progression is likely to occur. So we quickly changed the patient to 4 medications, and we found the pressure was still hovering around 18, 19. And because we could now begin to see changes on the perimetry, we actually had to go in and do a trabeculectomy. So POAG suspects, especially when you can see that there's a significant thinning, please be aware that, again, they're not going to gradually change. You can see here the change is very, very gradual. Here we changed to prostaglandins. Again, it was stable. And then suddenly you can see the loss here again. And therefore, we had to do a trabeculectomy. This gentleman, on the other hand, had angle closure glaucoma. And you can see that he was absolutely stable. All these years, he was stable. Pressures were 14 to 16 on prostaglandin and timolol. He moved out of Delhi, and somebody outside did a phacoemulsification and said, you don't require 2 medications. You're absolutely stable. So why don't we just make it a beta blocker? So they changed to a beta blocker, and he came back to us again with this kind of a steep drop. And here you can see the octopus is actually showing us where to look for changes on the optic nerve head. This is the polar trend analysis. So we thought maybe he's been on beta blockers for a very long time, for almost 7 to 8 years. So we took them off for 6 weeks, gave a stopgap brimonidine, then switched back again to dorzolamide, timolol, and prostaglandins. The IOP is now 12, and you can again see that it is becoming stable, and it's been stable over the last 4 years. So whether open angle or angle closure, please consider that, beta blockers do show waning over time. And people who have absolutely normal fields of very slight paracentral defects will tend to progress if you're not careful with the intraocular pressure. This gentleman had a open angle glaucoma, and what has been said is the first 5 fields can generally predict further changes. So we didn't have time to do 5 fields. He did 1 field and then decided that RP center was too difficult to come to. So he went to his local ophthalmologist. At the center, we had asked him to use a PG analog, and his IOPs were 15 to 17. He had very early glaucoma, so we didn't really bother very much further. He then was lost to follow-up for 7 to 8 years, and he came back to us with an IOP of 22, saying he was using on and off prostaglandins, but not very regularly. So when we explained to him the problem, we told him that your visual field is actually showing us very significant changes. We need to change your medication and get your target IOP now with a moderate glaucoma to about 12 to 15. He was willing to do it, and therefore we added dorzolamide and timolol. Again, you can see that once we added that, the progression seemed to sort of stabilize for a little while and then started again. So at this point, we did a trabeculectomy to make sure that no further changes occur. And for the last few years, he has been exactly there. What about the diagnosis of chronic simple glaucoma that we all see in our clinics? The patient will come saying, I have records over the last 5 years. The diagnosis is chronic simple glaucoma. And you look at the records, the pressure is 14 to 22 on Lumigan and timolol. There are intervision fluctuations which are 6, 8 millimeters. The patient has progressed from an absolutely normal field to biarcuate scotoma. So you must look carefully at the patient. You can see the shallow AC. You don't have to do anything more than that. You can see the Van Herrick. So when we did a gonioscopy, this was the picture that we got. And we therefore immediately did an iridotomy and changed her medication. Sometimes you can change from one prostaglandin to another. and get some extra efficacy if the other one has been used for a long time. We also added a combination of timolol and pilocarpine because we've seen this in PACG eyes that they actually work very well. And we tried the use of ROCK inhibitors. The pressure is now 12 to 14 and the patient has been stable for the last 10 years. To end, I would like to say that there are cases where the IOP off treatment is never more than 18 millimeters of mercury. But because of the look on the optic nerve head, the fact that this showed us collaterals, we put the patient on medications. That was a prostaglandin because prostaglandins can lower IOPs that are even within the normal range. We gave them brimonidine for the possibility that it has some neuroprotective effect. But we also went ahead and did a carotid Doppler and an MRI. And what we found was that there was an 80% block on both sides on the carotid Doppler, and the MRI showed us multiple microinfarcts. So in these normal tension glaucoma patients, please lower the IOP, but remember that they almost always have some other problems which need to be taken care of as well. Now, we did sort of think that we could try Ripacidil because they're saying again Ripacidil lowers IOP even in the normal range. We do give antioxidants and we do give vasodilators in these patients if they tend to show.
Madam, you can sum up.
Yeah, this is the last slide. Sorry, home monitoring is a possibility. This is the last slide. So the idea is that you stop the glaucoma wherever you see it. And this can be done if you diagnose progression early. So concentrate on already defective locations which are going to show deepening or widening. And the management is lower the IOP and most often lower it to less than 12. Do not miss angle closure. Check for steroid use. And even a cream put on the feet can cause problems as far as the IOP is concerned. And think about early surgery if you find the progression continues despite 3 or 4 medications. Thank you.
Thank you, madam, for an excellent coverage of a very difficult topic and a lot of insight. Thank you very much. And I would like to start with my next talk, which is I'm going to talk on raised intraocular pressure after very commonly observed after the cataract surgery. Am I audible and visible?
Yeah, yeah.
Yes, yes.
So good morning, and I will be talking on this subject of raised intraocular pressure after cataract surgery. It is a very common to observe this, and studies have shown that up to 24 hours, you have up to 18 to 45% patients who have had cataract surgery showing a spike. But in only 1 to 10% is the spike over 30 millimeters of mercury, and a large percentage of these patients, the pressures come back spontaneously within the normal range. However, these are the situations where the risk is there that this pressure spike can cause serious problems. The first, as we all know, is a pre-existing glaucoma and ocular hypertension group, where they already have pressure problems, and cataract surgery can precipitate a spike in them. Moderate myopia and patients with pseudo-exfoliation who still don't have glaucoma are more prone to get these kind of pressure spikes. The second clinical situation is where you have a posterior capsular disruption during the surgery, and we know that this increases the risks in cataract surgery of so many things, including a pressure spike. The retained viscoelastics have been researched extensively and have been reported to be a cause for the pressure spike, especially the dispersive type of viscoelastics, because they cannot be completely removed from the eye very easily. The factor that trainee surgeons or surgeons with less surgical experience, incidence of the pressure spike has been higher in this subgroup, probably because of the prolonged surgical time, excessive tissue handling, etc., and probably the higher incidence of complications such as the posterior capsule problems. IOLs which are placed in locations other than the capsular bag, such as anterior chamber IOLs, are associated with 38% of pressure spikes. and sutured posterior chamber IOLs also about a similar percentage of pressure spike. So if you know these situations where you are likely to face the problem more commonly than normal, then you can be more careful. So what are the mechanisms which play a role in this? As we know, inflammation and hemorrhages, even small hemorrhages can block the trabecular meshworks temporarily and cause the pressure spikes. Viscosurgical devices also are known to cause the blockage of the trabecular meshwork, especially as I mentioned, the dispersive types. Release of iris pigments by the IOL haptics and handling during surgery can also result in this. And of course, we have to remember that we all are using steroids in post-surgery after cataract surgery, and steroid response is known to occur, again, more likely in glaucoma patients and ocular hypertension. So when you have a scenario where you are anticipating that the pressure spike is more likely because of risk factors, you can do preoperative prevention. Acetylzolamide 250 milligram tablet 1 hour prior, or brimonidine 0.2% twice a day, 24 hours prior to the surgery, have been reported to be very effective in blunting these spikes and almost eliminating them. Intraoperatively, obviously, as we have mentioned, very good washout of the viscosurgical material and a short surgical time and placing the IOL most appropriately would definitely help. Also, intracameral injections of acetylcholine and carbachol are known to blunt these pressure spikes. However, once you have already had the pressure spike, how are you going to manage? Naturally, in most of these patients, majority of the patients, you are going to opt for medical management, and oral acetazolamide given for a short duration, extremely effective medications unless it is contraindicated. Topically, timolol by itself or in combination with brimonidine or dorzolamide, also very effective. And the new kid on the block, the Rho kinase inhibitors, because they are known to inhibit inflammation, especially repasudil, and some beneficial effect on the cornea. So you may use it in the postoperative scenario. However, drugs which fall into the category of prostaglandin analogs and pilocarpine, because they are known or likely to increase inflammation and can cause cystoid macular edema in cataract operated eyes, we would not generally like to use them in this scenario. Then there is an incidence, I already talked about the IOP spike which occurs in the early postoperative period. This is the IOP spike, which is called a late IOP spike, which occurs more than 10 to 15 days after the surgery. Very commonly either presents with pain, lacrimation, reduced vision, and sometimes redness. The possible causes are many in this scenario. As I mentioned right in the beginning, steroid response is likely to occur, and you have commonly missed secondary glaucoma scenarios, while some amount of small neovascularizations and angle recessions may be missed in your preoperative evaluation. Retained lens matter, sometimes you can, while doing the surgery, you have noted that some lens matter may have been retained because there was a posterior capsule rupture, but you have scenarios where lens matter can be retained in the absence of capsular disruptions and often missed by the surgeon. So when you have a late spike, you have to go back and examine the patient very carefully, and dilated examination also see the fundus, and sometimes you need to do additional UBM and B scans. The treatment will definitely depend on what you see. So as you can see here in this example, fine blood vessels are seen with a corneal haze due to the raised pressure. Sometimes the blood vessels are so subtle that you don't see them very easily, but they can result in the pressure going completely out of control. So management, as I mentioned, is going to be on the cause. So you have to look for the cause and determine what is disrupting the situation and treat accordingly. So if you have retained viscomatter or you have lens matter, then you would definitely like to do a surgery, repeat, and wash out the material. In secondary pupillary block scenarios, you would like to do a laser PI. If the IOL malposition is the cause because of low-grade inflammation and release of pigments, you will have to reposition the lens. And in some cases, because of neovascular glaucoma and angle recession, you have to manage appropriately to that. So this is a few examples of these late spikes. Patient suddenly who was doing very well with 6S vision comes one day with redness, pain, watering, and IOP spike. This is managed medically but recurs. That is the time. Gonioscopy is sometimes very valuable because a small retained matter of lens which is not visible on slit lamp is going to be seen on the gonioscopy. Non-diabetic patient presenting 1 month after the phacoemulsification with pain and reduced vision and a pressure spike. And you can see here florid neovascularization on the iris, which was obviously not there when you operated the patient. It was not there when you had seen the post-operatively, and has suddenly appeared afterwards because of retinal pathology, which was pre-existing but was missed. Again, a similar patient coming with recurrent complaints of pain and blurred vision. Almost a month after surgery, anterior segment is totally quiet, but when you do the B scan, you can see definite high reflectivity points in the vitreous cavity. This is lens matter, which is displaced down, resulting in some amount of inflammation and pressure spikes. And to solve the problem, you will have to go in. This is an early post-operative patient who had a small incision cataract surgery, not a phacoemulsification. And patient had severe pain and raised pressure very early post-op. And this is a UBM picture which shows you that there is an occlusal pupillary because of inflammatory material, and there is a lot of material which is collected between the iris and the lens, even though the lens is placed in the bag, but this is causing shallowing of the anterior chamber and raised pressure. So you have to look at these things, and appropriate management would be an iridotomy and anti-inflammatories, and you can solve this problem. This is a malpositioned lens. The one haptic is in the bag and one haptic is in the sulcus, and the IOL is touching the iris, causing rubbing of the pigment, release of pigment. Naturally, it is over time going to lead to pressure problems. And this is a patient who did very well, a very quiet eye. Patient had very good vision immediately after surgery. And in a few weeks, patient presented with some amount of corneal haze and pressure spike, and a gonioscopy showed an angle recession. As we know, angle recession occurs due to trauma, but it can present with glaucoma anytime afterwards, even years later. And if you have it that way, it can happen after a cataract surgery. So looking at your patients very carefully when you have pressure spikes and managing appropriately goes a long way in preventing further damage to the patient's eye and getting good vision recovery. Thank you very much.
Thank you, Manish. That was very comprehensively covered. I think these are common things which we don't really look for. We now have Parul, who's going to talk to us about contrast sensitivity and glaucoma.
Dr. Parul, you want me to put on your the presentation, and I can do it. So Parul had some problem regarding her.
Yeah, we all saw her message.
Yes, yes. So I will be playing her video for her.
We can't hear you.
Arun, you can start commentary.
Manish, is
Dr.
there
Manish?
Sound is not there.
Is there a sound? I think that sound is not coming.
Sound is not coming.
No.
I'll probably redo it.
Such high contrast is not usually seen. Very soft.
Ma'am, I'll do it like this. Dr. Manish, if we can just play it from the beginning, then I'll speak over this only.
Yeah. Okay.
Well, I'm so sorry for the technical glitch that I'm facing today. I'll be sharing my views about contrast sensitivity and glaucoma. So in our day-to-day practice, we usually focus on intraocular pressure, visual fields, and optic nerve head, but we usually fail to ask our patients what they are symptomatically feeling when the disease is progressing or when they are facing a moderate to severe stage of disease. So in real life scenarios, the contrast is not as bright as you see on a Snellen visual acuity chart. During dawn and dusk-like situations, the driving can become very difficult for such patients, and they take a while to adjust from coming from outdoors into the rooms when the light has to adjust. So this study showed that when the patients were asked what they saw in real life situations, they found that they needed more light, and blurry vision was one of the most common complaints that they had, in contrast to the traditional teaching of peripheral constriction of vision. So definitely contrast plays a very pivotal role in the life of patients with moderate to advanced disease. Next slide, please. So this is something that we really need to look at, because even in early glaucoma and in patients with ocular hypertension and pre-perimetric glaucoma, the quality of vision may be well retained, but the contrast gets compromised. And therefore, it's, I think, essential that we focus on this element too, because it's so important in target identification, wherein the day-to-day activities like driving, walking, and even facial recognition can get affected. And both central as well as peripheral contrast sensitivity gets affected. Till now, most of the tools had been looking at only the central contrast sensitivity, and a lot of tools were based on alphabet recognition. But the problem is that the alphabet charts, they fade over time, and the patients can remember the charts, and for illiterate patients, those cannot be used. But with newer computer-based techniques, tests like Aston test or the Spaeth-Richmond contrast sensitivity test, they are grading based, and they have taken care of the drawbacks of the previous test. And SPARCS is one of the tests which looks at both central and contrast sensitivity. So I'll be talking about a couple of studies from this test. I've been using it since past 3-4 years for my glaucoma patients. And this test actually checks both central as well as peripheral contrast. It's based on gratings. And there are 4 quadrants in the periphery. So each quadrant gets a score of 20. The central quadrant also gets a score of 20. So out of total score of 100, we get a comprehensive SPARCS score. So we can monitor our patients based on the changes in a particular quadrant or in the center or total score. So this study from the group that made SPARCS found that SPARCS score of less than 70 has been shown to have about 80% sensitivity and 93% specificity for glaucoma. So it definitely can act as a good tool in monitoring our glaucoma patients. So for the average patients, the score was around 60. The evolution of contrast sensitivity studies has shown that it was only lately that contrast sensitivity has been recognized as a predictor for rapid progression of glaucoma. So now with the newer pixel dithering techniques that are available for online contrast sensitivity tools, we are able to use contrast sensitivity as a better tool. So before we started using SPARCS in our practice, we thought, why not compare it with Pelly-Robson test, which has been there since very long. And we found that SPARCS has a potential to differentiate between different grades of glaucoma patients much better than Pelly-Robson sensitivity. It had a better sensitivity as well as specificity for detecting glaucoma. It has also been recently used in a study wherein SPARCS was used to stage advanced glaucoma, and it was found that the total SPARCS score, accumulative of the 5 quadrants, of less than 45 and less than 38 predicted severe glaucoma, and that corroborated with the mean deviation on the perimetry of less than -20 decibels and -30 decibels. So at the point when your OCT becomes redundant, the PSD is not available on the visual field printout, SPARCS in conjunction with mean deviation can definitely add an insight to what's happening at the center of the visual fields. Yet another study where Pelly-Robson test and FRACT were used as 2 contrast sensitivity tools in patients with advanced glaucoma, and the results reiterated the fact that despite near normal visual acuity, these patients have profound deficits in contrast sensitivity, and therefore contrast sensitivity assessment can definitely provide additional information on the central visual function for these patients. So whichever tool you have, it's a good idea to start using it, at least for your moderate to advanced patients. This study, which looked at visual field progression and contrast sensitivity, they found that SPARCS was able to predict rapid progressors vis-a-vis the Pelly-Robson test. So it highlights the fact that we really need to look at peripheral contrast sensitivity, which has often been overlooked till now. And even the parameters which required contrast sensitivity in rapid progressors were all subdued in patients with advanced glaucoma. So SPARCS definitely provided a hint to catch these patients well in time and provide a necessary therapy. So we also studied moderate to advanced glaucoma patients and followed them up for 2 years using SPARCS. And we found that the correlation between SPARCS and the mean deviation was non-linear, but the SPARCS scores correlated better with each other than mean deviation and pattern standard deviation, thereby suggesting that they are more robust indicators at the end stage disease and therefore can be used as a reliable marker to detect progressive changes. Now, in COVID times, a lot of our patients have not been able to attend our clinics for their regular visual field or OCT testing. So there is a new function with SPARCS which can detect 10, 20, or 30% change in a particular quadrant, and the patient can take up the test at their home. So an email is sent to the primary physician if there is any change, so that they can modulate the therapy accordingly. So since the patient can take the test free of cost from the comfort of their home, I think this is a good idea to at least have some sort of a marker. Does intervention improve the contrast sensitivity? And the answer to this is yes. So 60 to 70% patients have noted improvement in their contrast after institution of both medical as well as surgical reduction of intraocular pressure. So yes, a proper monitoring of contrast can give us an insight to what's happening. This paper is under review. So we gave treatment naive patients with no other history of contrast sensitivity, reducing conditions, travoprost, and we found that at all time points after giving the treatment, the contrast improved. So we should ask our patients if they are having problem with adjustment in light when they come from outside to the room. And we can suggest some measures like a higher contrast background to make their life better, watches which have high contrast, telling them to put pour milk in a darker mug so that they don't spill over. So light crockery can be avoided in places of dark crockery. And to cut the glare that is associated, yellow or amber tinted glasses can be suggested, and smartphones or tablets, whatever they use, have specific apps to make the contrast much better and make their life much easier. So with this, I would like to conclude that yes, contrast sensitivity is something which we really need to start looking at. Different contrast sensitivity tests exist. So whatever you are comfortable with, I think we can take a pick and start using that test. And extra focus on patients with moderate to advanced glaucoma should be given. And if we are seeing it, I think it's a good idea to pay a little bit of attention to the peripheral contrast as well, when you sometimes feel that the target pressure has been attained and the patient is still deteriorating. So maybe peripheral contrast can give us an idea. So with this, I wish everybody good health, and I wish everybody and their family remains COVID safe. So thank you so much.
Thank you, Parul. I think that was something that we don't actually look for. And I think none of us have this spark, but we should sort of definitely start listening to our patients when they complain about, I'm having more and more difficulty despite a 6x6 vision. We now have Dr. Mayuri talking to us about trabeculectomy blebs and hopefully telling us how to get good success out of them. Mayuri, we can't hear you.
I've already unmuted my. Can you hear me now?
Yes, but very soft.
At the outset, I would like to thank BOA and MA. Mumbai.
Could you increase the volume a little bit more, Mayuri? Am I the only one, or Manish?
No, all of us can hear her softly.
It is soft. Yeah.
So just...
I will try to be louder.
Okay, all right.
Yeah, talk as loud as you can.
I can shout, Rita. Okay, I will be talking in vivo evolution of post-trabeculectomy bleb. And we know that trabeculectomy is still most effective in filtering surgery, even though more and more new options are available now to us. The long-term data shows efficient control of IOP up to. Oh,
You have stopped sharing.
not,
Start share again. Yes.
can you see now?
It is showing the other screen. It's not showing your presentation.
Let me do it again.
Manjula, can you help?
Yes, doctor.
Can you see me now?
We can see you, yes, but
No,
not your screen.
Okay.
Hello. Doctor, can you open your file in desktop, doctor? Hello.
Yes, yes, I have already opened it.
Okay.
Is it okay?
Yes. Yes.
Can you see now?
Yes. Yes. Yes.
Okay. So in next 8 minutes, I will try to show you some of the pulse, how you can have a success. You can monitor your blood, which is the only data that you can use. The long-term success is already been shown by the Ramanji that at 20 years also you have a successful trap. But this graph is showing you that in initial phase it was highly successful, but then there is a steep downfall and then it becomes steady over a period of time. Up to 60 to 67% of the patients are successful. Now we have to find out what is happening at this level so that we can prevent the failure. Various classifications are available, clinical classification like Moorfield, which includes the bleb area, height, and vascular. But these are all subjectives. It may not be same for you and same for me. The Indian bleb morphological IBEX classification is better than Moorfield in a way that it has included the CEDALs also. And the new one which is available is the MEVEX classification, which has included the height, vascularity, and also the height of the transparency of the blood. It is transparent or non-transparent, but it also includes the micro assist appearance, conjunctival mobility, and the CEDALs. So whatever the comparison is shown here, everything is same with all the three, but the last one, the newer one, has the bleb transparency and microcyst in addition to the conjunctival mobility, which is also a sign of a good bleb, functioning bleb. So, but what is happening in vivo actually will give you more guideline, and with the help of the imaging technique, you can look what is there inside the bleb and decide on the functionality. So this is how we take the cross section from the bleb area. It should go with the center of the bleb and the horizontally at the exactly on the top of the elevation. And then once the scan is taken, various things that you can visualize here is the subconjunctival fluid space or suprascleral fluid space and multiple small anoic area which are showing you the aqueous drainage and the root behind underneath the scleral flap and the sclerostomy site. Various studies are there which has also shown that the ASOCT or the UBM can be a promising tool to know the filtering bleb functionality. And once you can know the features of this morphology, you can predict the outcome and you can manipulate accordingly. The ideal bleb should have a numerous microcyst, diffuse bleb, and the moderate elevation, but it can be better evaluated. You see in this photograph with the ASOCT compared to the slit lamp examination. It gives you so many details, the microcysts, the separations, and the multiple layers. And these are the identification of the ideal blab. Sometimes the clinical picture, the transparent blab with a good elevation could be a deceptive picture. Good looking blab may not be always a good functioning blab. As shown here, the thick fibrous membrane is giving you the elevation in this area, and it's not a very good functioning blab. So can we predict the failure by utilizing the modality? If we can we recognize it early? And if we can prevent, can we manage it in a better way? So the cause of the blab failure by and large is the vascularization and the fibroplasia subconjunctivally and or in the episcleral space. First, rule out the occlusion which is of the internal ostium, and then look at the suprascleral and subconjunctival space. But the most important step first is the recognizing its presence of the failing blab. So what I can say is you can predict the long-term success at 1 month after doing examination with this imaging technique. The blab wall with the multiform reflectivity showed increased chance of success of functioning of filtering blab at 6 months. Same thing, the blab pattern with the multiple internal layers and microcyst is also a highly successful blab for the future. These are some of the examples. The blab wall reflectivity is divided into uniform reflectivity. Here you can see the dense white area, which is the hyperreflective area. And many a time these blab shows the failure in the future. While the multiform reflectivity, where you can see the multiple these black areas or tiny cavities of the aqueous drainage, and these wall type of a blab carries high success rate. Again, the multiform blab wall reflectivity is divided into the multiple internal layer as shown here, or the subconjunctival separation. Usually it is seen in the initial part, and the multiple microcysts like this. So the third one is the ideal one, and the other two are the suboptimal. Root beneath the scleral flap can also be identified in a case where you cannot see the internal ostium due to some reason, but it doesn't carry any significance as far as the functionality prediction is concerned. Again, we should know that both eyes of the same patient may behave differently as shown in this slide. So we have also published one study to correlate where we correlated the morphological features of the blab on ASOCT at 1 month with the blab function, which is surgical success. IOP was compared at 6 months. And this is what we found out, that if the wall is having multiform reflectivity with the microcyst and subconjunctival separation, it is going to be a 100% successful blab at the long-term follow-up. This is the recent study, Japanese study, which has also shown one additional finding, that if the width of the filtering opening is larger or wider, then it is a good predictor. So they have used the 3-dimensional ASOCT. We know the dreaded complications, some of them are shown here of the MMC, and that's why the people have started using safer alternative, that is ologen blab, which gives you thick wall blab. Now, what is happening with this implant and blab is, I'm going to show in a couple of slides. The ologen implant is a biodegradable implant. It will absorb by 90 days and leaving behind its place of fibrous sponge, a negative copy of the. So the absorption of this will leave the microcystic space underneath it in suprascleral space, and at the end it completely absorbs, so there is a shrinkage of that material, the fibrous tissue, leaving the larger anoic area on the suprascleral space, which is not like mitomycin blab, and then subsequently you can see the microcystic area in the periphery. So this is day 1, first week appearance, homogeneous implant is seen. Only small area of the cyst is seen here. At 3 months, you can see that something is coming up here. translucent area of the aqueous, and few aqueous separations is also seen in aqueous cyst as there. And at the end of 12 months, you can see a clear cut aqueous pocket here, one more here. So basically there is a shrinkage
We
of
need to wrap up.
membrane. So last slide is to show you the tenant cyst, what happens after the completion, needling. There is a flattening, and at the end of 6 months, it was a functioning small space here. So implication is you can have a better understanding of black morphology, you can predict this outcome, and you can manipulate accordingly. Thank you.
Thank you very
Thank you,
much,
Dr.
Dr. Mayuri. I think what we'd also like to know is, if they're failing, what should we do? So maybe that's a question that you can answer at the end if we have time. We now have Dr. Indira Durai talking to us about a complicated sort of glaucoma, which is difficult to treat in most cases, aniridia.
Good afternoon, everyone. At the outset, I'd like to thank all the organizers of BOA and Dr. Manisha for giving me this opportunity. So today I'll be talking about glaucoma in congenital aniridia. So a 17-year-old male was referred to us with bilateral congenital aniridia and refractory glaucoma on maximum medical therapy with no history of any prior ocular surgeries for further management. The patient was found to be monoocular with no perception of light at the right eye and having a best corrected visual acuity of 20/200 at the left eye. Anterior segment examination of both the eyes revealed conjunctival xerosis with pannus, total aniridia, a clear lens with pendular nystagmus. Fundus evaluation revealed a glaucomatous optic atrophy in the right eye and a cup disc ratio of 0.8 in the left eye, along with foveal hyperplasia. The intraocular pressures were found to be 40 mm of mercury in the right eye and 30 mm of mercury in the left eye, recorded by Goldman's applanation tonometer, and central corneal thickness was found to be 600 microns in both the eyes. Gonioscopy revealed rudimentary iris stump with extensive synovial angle closure in both the eyes. Systemic examination of the patient was unremarkable. On further evaluation, the younger sibling was also found to have bilateral aniridia with secondary glaucoma. Since intraocular pressure was uncontrolled on maximum medical therapy and the patient being monoocular, we decided to proceed with an Orolab aqueous drainage implant surgery. A fornix-based conjunctival flap was raised in the superior-temporal quadrant of the left eye. The episcleral plate of the RD implant was then placed beneath the lateral rectus and the superior rectus muscle. The episcleral plate was then sutured to the sclera using a 9-0 nylon suture on both the sides, ensuring that the knot is properly buried beneath the plate. A box suture using a 9-0 nylon was then placed to stabilize the tube. The tube was then ligated using two 6-0 vicryl sutures proximal to the end plate. Occlusion was then confirmed with a 27-gauge cannula. The tube was then cut in a bevel fashion, keeping a length of 2 mm from the limbus. The scleral bed was then cauterized. A 23-gauge needle track entry was then placed at an incision which was 4 mm from the limbus and 2 mm lateral to the tube. The anterior chamber was then entered with the 26-gauge needle. The tube was then inserted through the scleral track into the anterior chamber, ensuring that the tube is placed over the periphery, over the lens zonule, so as to avoid injury to the lens capsule. The conjunctiva is then sutured with a 6-0 vicryl suture. Ocular hypotony was noted at 1 month follow-up visit due to autolysis of the ligature and was managed conservatively with cycloplegics and steroid eye drops. The intraocular pressure was found to be 14 mm of mercury at the 2nd month post-operative visit. The IOP was then maintained in low to mid-teens till the last follow-up visit on topical monotherapy. Aniridia is a rare hereditary bilateral congenital anomaly characterized by profound hyperplasia of the iris, frequently associated with ocular anomalies such as corneal pannus, keratopathy, cataract, ectopia lentis, and foveal hyperplasia. It is inherited in an autosomal dominant fashion in 2/3 of cases, or in a sporadic manner in 1/3 of the cases, and associated with a mutation in the PAX6 gene on chromosome 11. About 20% of patients with sporadic form of aniridia have been found to have Wilms tumor. The incidence of glaucoma in aniridia ranges from 6 to 75%. It is uncommon in infants and newborns and typically presents in late childhood or early adulthood. In patients presenting with infantile glaucoma in aniridia, the mechanism of glaucoma is usually due to cleavage abnormalities of the anterior chamber angle or dysgenesis of the Slem's canal, whereas patients presenting with early adulthood, the glaucoma usually occurs due to progressive opposition of the stump of the iris to the trabecular meshwork. The severity of glaucoma in these cases is related to the extent of synechial angle closure due to the residual iris stump. Rarely, secondary angle closure from ectopia lentis, intermittent lens, or falling surgery for cataracts or glaucoma has also been reported in these cases. The treatment of aniridic glaucoma consists of medical therapy, laser treatment, and surgery. The initial treatment is usually with medical therapy directed towards control of intraocular pressure, consisting of aqueous suppressants and miotics. Organ laser trabeculoplasty has been found to be ineffective when performed in these eyes with open angles. Eventually, a majority of patients with aniridia will require surgical intervention for uncontrolled glaucoma. There are several options available in the surgical armamentarium for the management of aniridic glaucoma. But goniotomy is usually indicated in young children without glaucoma, but having extensive synechial iris extensions across the scleral spur, or showing evidence of worsening of angle abnormality on gonioscopy. Chen and Walton reported a success rate of 89% following prophylactic goniotomy in 55 eyes over a follow-up period of 9 years. In infantile aniridic glaucoma, trabeculectomy is the procedure of choice. So previous studies have reported a surgical success of 83% in 10 out of 12 eyes over a mean follow period of 9.5 years after 1 or 2 trabeculectomy procedures. However, in young adults, these results are not promising. Trabeculectomy with mitomycin C is usually performed in eyes which is refractory to medical treatment. Nelson et al. Reported successful outcomes after trabeculectomy in 11 of 14 eyes at 1 year follow-up period. However, Wiggins and Tommy reported a surgical success rate of only 7% after trabeculectomy and a need for additional surgery, especially in young patients or phakic patients. Glaucoma drainage devices have been shown to be effective for aniridic glaucoma. Previous studies have reported a success rate ranging from 83% to 88% at 1 year follow-up period. I would like to share the results of a recent publication from our team at Arvind comparing the outcomes of RD implantation and trabeculectomy with mitomycin C in patients with glaucoma along with seen in aniridia. So ours was a retrospective case series comprising of 30 eyes in 30 patients. In our study, the surgical failure was defined as an intraocular pressure of more than 21 millimeter of mercury or reduced less than 20% from baseline, or an IOP less than or equal to 5 millimeter of mercury at 2 consecutive visits after 3 months following surgery, or those requiring reoperation for glaucoma or presenting with a complication or presenting with the loss of perception of vision, light perception following surgery. So in our study, 12 patients underwent trabeculectomy with mitomycin C and 18 patients underwent RD implant surgery. Our study reported a cumulative probability failure rate of 58% in the trabeculectomy group and 11% of failure in the RD group, and a success rate of 42% in the trabeculectomy group and a success rate of 89% in the RD group. The mean intraocular pressure at 2 years follow-up was found to be significantly lower in the RD group compared to the trabeculectomy group. There was no significant difference in the complications between the two groups. However, a significant number of reoperations was observed in the trabeculectomy group, with patients requiring 5 reoperations for glaucoma and 5 for cataract, whereas no reoperations was observed in the RD group. So our study concluded that a placement of an RD resulted in lower intraocular pressure and a higher rate of surgical success compared to trabeculectomy with mitomycin C in eyes with glaucoma associated with aniridia, and cataract extraction was more frequently required after trabeculectomy with mitomycin C than with RD implantation. Cyclodestructive procedures are performed only in cases refractory to medical and surgical therapy, and it is usually not recommended as a primary intervention due to higher rate of complications such as cataract or phthisis bulbi. Wiggins and Tommy reported a success rate of 120% after cyclocryotherapy.
your presentation.
Hello?
Will you please sum up?
Yes, ma'am. So last slide. So to summarize, glaucoma in aniridia is difficult to control both medically and surgically. Routine gonioscopy is critical to guide appropriate prophylactic or therapeutic intervention. Gonius surgery, either trabeculotomy or goniotomy, may benefit young aniridic patients with glaucoma who exhibit open angles. In general, GDD may be more successful than gonius surgery, glaucoma filtration surgery, and aniridic glaucoma. Cyclodistrictive procedures are usually reserved for refractory cases, given the high rate of complication. And the best approach may be to prevent or delay aniridic glaucoma by prophylactic goniotomy in eyes that demonstrate progressive anatomical changes in the drainage angle. Thank you.
Thank you for that elaborative lecture. Now I invite Dr. Shushmita. She doesn't need any introduction. She's going to talk on congenital glaucoma. It is her passion, I believe.
Are my slides visible? I think you'll have
Yes.
to. They are? Okay.
But it's not full screen.
Yeah, I will. Okay, is that better now?
Yes.
Yeah.
Good morning, everybody. Thank you, Manish, and thank you, BOA, for the opportunity. So yes, as Dr. Mayuri said, these babies would be anybody's passion once we start working with them. I've taken informed consent from all parents to share their pictures freely for academic purposes. So what we look at today is one surgery is done. I presume congenital glaucoma would have undergone surgery. So one surgery is done, what next? When to call back, what to look for, how to evaluate them. Do you do UA? Is sedation enough? What are disease progressors despite so-called controlled intraocular pressure? Now that's another problem in children. How do you look at cornea? How do you look at axial length? And even if disease stabilizes beyond the IOP, I can't emphasize enough on how much we need to look at vision, and vision. So the first question is, when is the eye patch opened? Among the things that COVID has taught us, one is to do bilateral surgery and do it a little more fearlessly than we did it before, simply because we know we're going to reduce the admissions, reduce the travel, and it's worked out very well. So for instance, this baby with garden variety infantile glaucoma, and when we do bilateral surgery, the child, by the time it gets out of GA, is so annoyed at the world. So we just take out the patch in maybe 4 hours after that when they're accepting orally. And to our surprise, when we started doing that, most of them have actually cleared as early as 3 to 4 hours after surgery. And the children actually are less photophobic and they have less blepharospasm and they seem to be quite all right. And whether there is hyphema, whether there is inflammation and all that will direct the next steps. But usually it's a combination of steroids and antibiotics for the next 3 to 4 weeks. And then what next? So we've learned that the most important thing to look for is the child's comfort. So if you have an irritable kid like this who came to you and 6 weeks later wants to sit on the slit lamp and show herself, you know that probably the kid is better. And the mother's feedback is important. The first thing to ask the mother is, what do you think? What is your child like now? Of course, corneal clarity, intraocular pressure if possible, now that the eye care is available. But something that we really, really have found useful is the axial length. So the cornea and the axial length are actually surrogates for the intraocular pressure. I know the eye care has been touted as the greatest thing to have come in, but it's important to understand that Goldman applanation tonometry in awake children is the most accurate method. Whether you can do it or not is another matter, but that is the most accurate method for intraocular pressure assessment, even in children. Rebound tonometry does overestimate the intraocular pressure, and this overestimation increases with increasing CCT as well as increasing IOP. So the higher the IOP, the more chance that the rebound is going to overestimate it even more. Now, sometimes intraocular pressure might be normal because these are elastic eyes. And if the eye is going to expand under a raised pressure, you're not going to be able to measure it. So for instance, this preterm baby with ROP who'd undergone both eyes LIO and then LSV, and 4 weeks later actually came with this large cornea. So the IOP remained okay when we put her on medical treatment, just holding on to what is the next best thing to do, because we were so scared that the retina might detach if the pressure went too low. And yet the axial length kept increasing beyond. So what we use is the Sampolsky's graph, which is a graph of the normal growth of the eye up till about 5 years of age, because we know that the normal eye is going to grow as well. So the change is important, but it's very difficult to assess in the clinic whether this change is part of the normal growth of the baby or is it more than that. So this is a routine. This is from a clinic file. And finally, we did do a CTT, waited at least about 6 weeks to do the CTT because we wanted the retina to be settled. And after that, you can see the axial length growth has actually plateaued and is parallel to the normal. So the axial length is something that we've started using very often. Similarly, this baby, you can see the red is the right and the blue is the left. So started off beyond the normal, and then they actually do come down. And then with the growth of the eye, it is exactly parallel to what you expect it to be. So now, even if everything is fine, so at this stage, something that we are really concerned about is sutures, because we don't really look at them so much, these children, but then everything was fine, the cornea is clear, the pressure is fine, the axial length is fine. But then if you have a suture, which is accumulating mucus, that's another pointer to take for an EUA, because it can be very, very dangerous. So the follow-up examination would be about 6 to 8 weeks after surgery. Usually, if any intervention is planned, you have to schedule your examinations. And if the examination is satisfactory, the subsequent ones, we do it only about 4 monthly in the first year and then 6 monthly thereafter. So what do we look for? We compare with the pre-op status, of course, intraocular pressure, but corneal clarity, corneal diameters, sutures, if you've done a trabeculectomy, the bleb, if you've done a tube, the tube position, because remember, they have a tendency to go towards the cornea. The disc status and retina every time. That's something that is often overlooked, and the axial length. We compare with the pre-op status, of course, intraocular pressure, but somebody is recording this. So anyway, so the bleb, if you've done the tube position, because remember, they have a tendency to go towards the cornea. Manish, is status and retina every time. That is often overlooked. I can hear you. Can you all hear that? Compare with the pre-op status, of course, intraocular pressure.
Yeah, I think it's, isn't.
Is it being recorded? I mean, Manjula, can you stop the live recording or whatever?
I'm checking, doctor.
Please, I can hear the older side.
Face the same problem.
Okay. So sometimes we even have to do a secondary intervention.
We can't hear.
Sorry? Is it being recorded? I mean,
yes, it is being recorded.
Live recording, but I can hear the echo again.
Hello.
Hello. Is that okay, or should I carry on?
Yes, carry on.
Yeah, okay.
You can carry on.
So sometimes there is a secondary goniotomy, and this is a combined trab with trab, and you see the cornea is not as good as you would expect it to be, though it's better. We did the OI in the left eye, and then because the cornea kept getting hazy, so sometimes the IOP could be all right because there's persistent corneal edema, and your intraocular pressure is falsely low recorded. So look at other things. The point is that in children, intraocular pressure cannot direct your further management. So for this baby, even though the pressure was fine, the corneal haze made us intervene, and then a secondary goniotomy, which means we just do a goniotomy of the nasal angle, and then this cornea cleared. So you need to recognize the risks of repeated general anesthesia. We've published this on dexmedetomidine, and it actually came about because we simply didn't have enough GA time to do our EUAs. And I can share with you a short clip, and this is what is usually done. So they're in the preoperative room, the child is fasting, the anesthetists monitor, but at least GA is not given. And this is the atomizer with which it's just given intranasally. And once we have that, I acknowledge my senior resident, Dr. Deepika, for making this video for me. So it takes about 2 minutes, and the child is then nicely sedated in the mother's lap, being monitored both by SpO2 as well as the ECG monitoring. And the entire EUA can be done without general anesthesia in the preoperative room while I can carry on with doing surgeries of the babies that I have to. So this has worked out very well for us. And it's a caveat that you can use sedation as well. So after successful surgery, the intraocular pressure, okay, this is acute eye drops. You see the cornea is completely cleared. He's 4 years old now. Is your job done? So the question is, beyond the IOP, retinoscopy, spectacle prescription, visual acuity assessment, visual access assessment, amblyopia, visual fields later. We can't get rid of all this. There's so much beyond the intraocular pressure. You have a residual scar like this, probably requires an OI. You have Peters in one eye, PCG in the other. Your UBM tells you that this is going to be a very, very difficult thing to do. So you might as well just do an OI for this. This girl now goes to school and is 618 with just this OI, while the cornea guys are wondering whether to tackle this other eye or not. Unilateral ophthalmos have other problems. They have very, very high myopia. Their contact lenses just fall off on their cheeks. So I acknowledge Kulbhushan, our optom, who's made this and said, Madam, I can't fit a contact lens on your ophthalmos babies with blebs. So this boy was actually minus 22 in one eye by the time we got to him. And we did a refractive lens exchange, much as I hate admitting that. But he actually had a -4 diopter lens in this eye, which actually has treated the amblyopia very well. But my fingers are crossed for future retinal detachments and God forbid anything else. So to summarize, childhood glaucoma is a lifelong disease as all others, except that the lives of these children are so much more. And they can manifest in myriad forms. There are multiple etiologies which we need to talk about. So much is unknown. But at the end of the day, ensuring vision is our goal and not IOP control. But remember, we need to hold these children's hands with us for a long, long time to come. Thank you for having me. And I acknowledge all the residents and senior residents who helped put this together. Thank you.
Sushmita. The next is Dr. Rajul Bhai. He is going to talk on how to fix up the most difficult aspect of the management of glaucoma, that is adherence.
Good afternoon, everyone. My voice clear?
Yes.
Audible? So thanks BOA, MOS, Manish Bhai, Nane sir and Ragini madam. I will be talking about the adherence issue in medical management. Now, we know that glaucoma is a big issue. I'm not going to talk about epidemiology. We know that the awareness of glaucoma is poor in India. And because of that, we get lots of patients in the moderate and advanced stage. And though glaucoma does not cause the high mortality, it causes severe hampering in the quality of life, not only the physical activity, also in the psychological aspect. So glaucoma is dangerous and we have to take care properly. Now, when we talk about medical management, along with all the criteria, one of the things we talk about that the drug, the dosage should be such that it should be the patient compliant. So when we talk about the compliance, there are two issues which comes in picture. One is adherence and one is persistency. So I just define them. That adherence means the degree to which the patient follows the treatment instruction during the finite period of the time. And persistency means the time until which the patient first discontinue use of medication. And we must remember that both are not the same thing. The patient can be persistent and can be poorly adherent to the medication. So maybe he's putting drops like every day, but the time can vary and that is a poor adherence. So like, for example, we are given prostaglandin once a day at night time. If he is putting one day 10 p.m., other day 6 p.m., other day next day early morning 5 p.m., he's putting the drops. But the adherence is very poor, and that also is a problem with as far as the management is concerned. Now both, and if you look the Indian data, the nearly 75% of the patient fail to attend to the at least one follow-up visit. This is, I have taken data, I have given the publication below. Only 10% continuously refill their prescription over a period of 1 year. 50% patients stop taking medication within 6 months. So the adherence and persistency, both are poor as far as the medical management is concerned. And this is not only India, this problem is universal. Now, what happens that if the patient is poorly adherent or poorly compliant, what happens that the IOP control would not be great, which would lead to the high complication, and in glaucoma, basically a poor outcome in terms of the blindness. So the adherence is a big issue. We have to look in carefully in every patient. Just because patient says that I'm putting drops properly doesn't mean that he is adherent to the medication. And this is the data, more or less, if you look across the world, the common cause of the poor adherence remains more or less same. The difficulty in drop administration, the number of drops, if the scheduling is a big issue, poor knowledge, and the beliefs. Now, belief can vary according to the region, but the poor knowledge, wrong beliefs, and along with the difficult schedule, the difficulty in administration, the side effects. These are the common cause of the poor adherence of the medications. Now, what we can do to improve, the first, I have not written here, but the most important thing is the chair time. You give proper time to the patient, explain the patients in every visit, that is very important. Along with that, reduction in number of medication, fixed molecule over the unfixed molecules, then less preservative. So if you can give preservative free, which comes in the cost which patient can afford, then perfect. Otherwise, the fixed molecule will have a less preservative exposure to the patient because the number of bottle would reduce. And the fourth, you choose the molecule which is close to the neutral pH, so patient doesn't have side effect. As far as the drops going in the acidic, away from the neutral pH, the side effect increases in terms of the burning, irritation, and all this eventually leads to the ocular surface disorder and poor adherence. So the comfort of drops is very important, and which leads to because patients should not have any side effects of putting drops. Anyway, patient is having problem of his disease, and you don't want to give extra problem. So the drop should be such that it doesn't cause side effects or discomfort to the patients, because the discomfort would increase to the poor adherence. Now, second issue, we must remember that even in ocular hypertension, old study, at the end of 45 years, 40% patient required more than one medication. And collaborative initial glaucoma treatment study, which was based on the target IOP, which we follow in clinical practice, more than 75% of the patients required more than 2 molecules within 2 years. So the high number of molecules is a norm in day-to-day practice. What happens is that when you give multiple drops, the adherence reduces. So if you look at the data, at only one drop, the adherence is 81%, reduces to 50% when you give 4 molecules. So that is the one big aspect we have to remember in clinical practice. Now, other way around, this study what they did, they shifted from the unfixed to the fixed combination. And what happened, that unfixed, the adherence was only 60%, which increased to 80% when we went to the fixed molecules. So the fixed molecule, because the number of drops, the reminder they have to keep for themselves is less, the adherence improves. Also, second thing we must remember that when the number of drops,
Rajul, we'll have to wrap up a bit early.
But you have to give me at least 1-2 minutes, Manish.
Yeah.
I will finish on time. Don't worry about it. So we have
1 minute.
We have, ma'am, please. Everybody took so much of time. You give me enough time. We have combinations which is beta blocker and non-beta blocker. So in day-to-day practice, the beta blocker combination is most commonly used. Now, when we talk about the combination, we have to remember 3 issues: efficacy, adherence, and tolerability. Now, I will give some data of the fixed combination of the brinzolamide timolol, which the brand molecules, which is recently launched. Now, they had lots of publications. I'm not going to talk about it, but when they compare with the isolated molecule of brinzolamide timolol, the fixed combination had a much better IOP reduction of at least 2 to 3 millimeters. When they compared along with the equivalent dorzolamide timolol, because that is the older molecule, and we must compare the older molecule, and they found that IOP reduction was same. So the non-inferiority, so that means both molecules are same. Now, when both molecular efficacy is same, the newer molecule has to be better than the older molecule in some way. The only benefit was that the brinzolamide timolol combination, the ocular side effect was significantly less. and there is various publication. This was a crossover study to see the objective was looking the side effects, and they found that majority of the patient, 80%, were preferred the brinzolamide combination because of the less side effect. So InGen took the same thing. So to conclude, we know that glaucoma is irreversibly blinding disease. We know that poor adherence is a big issue as far as the glaucoma management is concerned. Adherence is we have to deal with it in making the patient more adherent. There is no science. It is more of a logic and common sense. We have to deal with the individual patient in a different way. The fixed combination is beneficial because it reduces the number of drops. It is much better for the patients. And when we are giving the fixed combination, we have to give the drop which causes the less side effects and has a better tolerability. These are the main points when we deal with the medical management of glaucoma. Thank you.
Thank you, Rajul. And I think we'll have to wrap up quickly because we are already behind time. I would like to pass to Dr. Sushil to give his talk on SLT.
Hello, everybody. Is my screen visible?
Dr. Sushil?
Yes, sir. Is my screen visible, sir?
No, no. Share your screen.
Okay. Now,
Yes.
okay. Can I proceed?
Yes.
Okay, so I'll try and make it concise. I'm going to speak on SLT in glaucoma. At the offset, I would like to thank BOA, Dr. Lahane sir, Ragini madam, Manisha sir for this opportunity. We are already covered with the persistence and the adherence issue. That makes my job a little simpler. So this is my outline, why SLT, what is SLT and how different is it? Available literature evidence on it and points to ponder while performing SLT. So if we see the timeline, we have evolved over a century with just pilocarpine and later on timolol available to a gamut of 6 classes of anti-glaucoma medications. Out of those, still around majority of the drugs which are used now are the prostaglandins. And all these medications do come with potential side effects. The triple H side effect of prostaglandin is very commonly seen, the hyperemia, hypertrichosis, hypopigmentation. This is well covered by Dr. Rajul Parekh sir and makes it easier to understand that only around 20% of the patient persist with anti-glaucoma medication at the end of 1 year. Surgeries also are quite often seen with long-term complications, and quite often they are dreadful with blebitis and bleb leaks. So if we see the surgical trends, we can see the surgeries have remained more or less stagnant in the lowermost yellow and the green chart. The light blue chart shows the ALT numbers decreasing, but from 2001-2002 year, that is the time when it was approved by American US FDA for use in treatment of primary glaucoma, the numbers of laser trabeculoplasty have significantly kept increasing. So what exactly is SLT? It's a Q-switched frequency doubled NDR laser of 532 nanometer wavelength. It's a single pulse, 3 nanosecond pulse duration, has a broad 400 micron spot size, air cooled, and it permits selective targeting of the pigmented trabecular network without causing structural or coagulative damage to the trabecular network. So if you see comparison of the parameters of SLT and ALT, energy is very, very minimal. It's around 0.6.
Continue. Please continue. Dr. Deshmukh, please continue.
We can't hear him. Can somebody call and
He's
tell
got
him?
muted. Sushil, you are muted. Unmute, please. Technical team, please unmute Dr. Sushil.
Yes, Dr. Unmuted.
Hello.
Yeah, you were muted for some time. Now we can hear you.
I think someone else spoke and then it automatically went into unmute. Is my screen visible, ma'am?
No.
Yes, yes.
Yes.
Visible.
Yes.
Okay. So if we see the trends of SLT have increased consistently from 2001 onwards when it was US FDA approved. These are the parameters of SLT. It's a 532 nanometer QSH double frequency Nd:YAG laser with a 3 nanosecond pulse duration and 400 micron spot size. It's air cooled and this permits selective targeting of pigmented trabecular meshwork cell without causing any collateral damage to the trabecular meshwork. So if we compare ALT and SLT, the energy used is very, very minimal, around 0.6 to 1.4 millijoules, 6 millijoules per mm square of fluence, and exposure time is fixed at 3 nanoseconds. So this short pulse duration and low energy allows targeting only the pigment cells, causing less of a collateral damage. How does an SLT work? The cellular photoactivation causes the release of cytokines and interleukins. Cytokines then in turn activates the macrophages to cause cell trabecular meshwork debris to be cleared out. And the interleukins over a period of time act as a growth factors and cause tissue remodeling of the trabecular meshwork, giving us the long-term control of IOP. This vitality study slide shows us the minimal collateral damage caused by the selective laser trabeculoplasty. On the right side, we have the picture of the SLT vitality study showing most of the cells are stained green and indicating viable trabecular meshwork cells. This shows the coagulative necrosis in the left picture of the ALT, whereas non-coagulative changes in the SLT. So coming to the treatment protocol per se, we now usually cover 360 degrees in the initial setting itself, and we give around 100 adjacent spots non-overlapping fashion. Spot size is fixed at 400 microns and the duration is also fixed at 3 nanoseconds. We start with a power of say 0.6 millijoules in each quadrant, slowly titrating based upon the appearance of the cavitation bubble, or commonly called as the champagne bubble appearance. Energy is slightly reduced by 0.1 millijoules from this threshold and used to irradiate that particular quadrant. It can be increased or decreased depending upon the response. So this is a small clip showing the similar thing. The 400 nitron helium aiming beam is focused on the posterior trabecular meshwork. Try and avoid overriding it on the iris root, which could cause pus formation in the later period. Also, do not confuse pigmented Schwalbe's line for a pigmented trabecular meshwork. That would also give you suboptimal result. So this has to be titrated in each quadrant, and we proceed to all the 4 quadrants by rotating of the SLT Latina lens. The post-operative care, we observe the patient after 1 hour for IOP measurement and the slit lamp examination. If the IOP spike is more than 5 millimeters of mercury, then we give a stat 1 tablet of Diamox 250 milligrams. And post-laser medication, usually we don't give them any NSAIDs or steroids. If there is inflammation, AC reaction seen, then we can use topical ketorolac for 3 days, TID. And in very rare cases, if we have severe inflammation, then we can give topical dexamethasone only 3 times a day. Using steroids in the post-operative period could decrease the IOP reducing effect of the SLT. So indications are primary treatment of glaucoma, OHT, and mild to moderate POAGs. Could also be used in PXL glaucoma and PACG in post-PI or cataract surgery once you have an open angle. Financial constraint for medicine use, non-compliance, drug side effects like ocular surface diseases, drug allergies, and tachyphylaxis, and as an add-on to anti-glaucoma medications. We definitely tend to avoid in neovascular glaucoma, angle recession glaucomas. In normal tension or low tension glaucomas, the response is poor. And in secondary or inflammatory glaucomas, like post keratoplasty or VIA surgery, you could have a suboptimal response. IOP spike is seen in around 10% of the patients and expect in hyperpigmented trabecular meshwork and in young patients. It could also mean that you are over-treating, so you need to titrate your energy to a lower level. And usually you need to have patients and the IOPs normalized with a few medications. So SLT has been advocated as the primary therapy. We can see if used as a primary therapy, the success was as high as 82% at the end of 5 years. As against to a secondary SLT, the success rate was only 30 to 40% at the end of 5 years. So this papers also justify the same. So they have concluded that IOP reduction was similar in primary therapy equivalent to a latanoprost group. These are some of the other studies which validate use of SLT in primary open angle glaucoma, especially in the early mild to moderate glaucomas. Advanced glaucomas, there were additional need for interventions in terms of the surgeries. If you go to the other group of subset of glaucomas, like the PXF glaucomas, the success rates were moderate, but in normal tension and the low tension glaucomas, the success rate was hardly around 10 to 20%. Steroid glaucomas and silicon glaucomas showed a success rate of around 46 to 59%. So to summarize, SLT is effective as initial or a replacement and adjunctive therapy in open angle glaucoma and could be used in angle closure also post iridectomy or cataract surgery. It is useful in addressing compliance issues with medication. It is effective in flattening the diurnal IOP curve and decreasing the nocturnal IOP spike. It also decreases the cost and side effect of the medications for the patient. Lastly, tip to avoid disappointment could be to do not overpromise the patient. Primary treatment works best. Choose retreatment in patients who were responsive and treating 360 degrees at first sitting, and avoid areas of synechiae or ostium for the SLT. Thank you again to the BOA and Manisha.
I think I'd like to thank all the speakers, and I think most of them kept to time except Rajul. And I didn't say thank you to BOA earlier because I only had 10 minutes time. So I'm thanking BOA now for allowing me to speak. And I think this was a very interesting session. Thank you all the speakers, and thank you for the organizers.
Thank you all speakers, and thank you, madam, and all the chairman, co-chairman, moderators. And I think we have to end this session now. We are already overshot time. Thank you.
Thank you.
Thank you. Thank you. Bye bye.